The peak incidence of GIs is the preschool boys or girls are 3 times more affected than the boys. In most cases, the uveitis is non-granulomatous, but granulomatous uveitis can also be reported occasionally. The most common extraocular feature of the GIA is uveitis. It develops approximately 11 to 13% of in GIA-associated uveitis. In patients with oligoarthritis, less than 4 joints, the risk incidence increases to 41%. 58% of these eyes had a final vision of 20/200 compared to the 3% of the group with just clearance cells. Development of glaucoma, cataract requiring surgery, cystoid macular edema, and recurrent episodes of ocular hypertony resulting in even itis bulbi. Hypotony is one of the very severe complications of GIA-U and any other uveitis due to the chronic inflammation and damage to the secretory ciliary epithelium. Male gender was found to be more responsible to the hypotony. Treatment, the first treatment option is the topical steroids with or without short-acting mediatic psychopathic agents. 97% of the uveitis specialists today believe that systemic immunomodulatory agent is required in such condition, and methotrexate is the first choice in many of them. And is a very efficient and tolerable drug, methotrexate, in children with GIA. 73% pediatric uveitis now, with the advent of biologic agents, they choose biologic agents, and most preferably the injection adalimumab, and some of them choose injection infliximab. There is an elegant study by Professor A.V. Ramanan who used adalimumab plus methotrexate for juvenile idiopathic arthritis associated uveitis and found to be very effective. And this study was prematurely terminated due to the very good efficacy of adalimumab plus methotrexate. So there are several surgical procedures that required: lensectomy, vitrectomy, PECO with IOL, EDTA chelation, penetrating keratoplasty, trabeculectomy. Uveitis and rheumatologists work in collaboration in managing this type of uveitis. Another case, 16-year-old boy, returned attack of pain, redness, and blurring of vision, had history of recurrent fever with systemic hypertension. Renal biopsy showed acute interstitial nephritis. Urinary beta-2 microglobulin was elevated. And this is a pathology slide of which I got, and you can see the acute interstitial nephritis with the surrounding the glomeruli. There is a chronic inflammatory cells. And this patient has non-granulomatous anterior uveitis in both eyes, resolved with topical steroids, oral mycophenolate, and prednisolone. This is a tubular interstitial nephritis associated uveitis. Here, uveitis specialists worked with a pediatric nephrologist to manage the condition. This is another case, 8-year-old male child, sudden onset of pain and redness and dimness of vision in both eyes for 1 month. And then granulomatous anterior uveitis with copies and Buschak's nodules are seen. And this patient had abdominal arthritis involving interphalangeal joints and maculopapillar dermal rash. And this after treatment with injection adalimumab, a 2-year follow-up, the patient got back the vision and the inflammation resolved. What the patient was having was a Bloss syndrome, and this patient was treated with biologic agents, injection adalimumab. Here, uveitis specialists worked with dermatologists and rheumatologists together. Intermediate uveitis in children is a severe disease with poor prognosis, band-shaped keratopathy, mimics GIA-associated uveitis, and they can have snowball exudates or snow banking, and they have got high risk of development of complication in children. They can develop cataract, secondary glaucoma, vitreous hemorrhage. Here, need to rule out systemic disease, especially TB and sarcoid. Uveitis specialists need to work with an internist. Infectious uveitis, an infectious cause, is responsible to 6 to 30% of all cases of pediatric uveitis. It can be toxoplasma, toxocara, TB, rubella, and is a congenital toxoplasmic retinochoroiditis, which is we are seeing less and less now. Nothing much you can do about it. But in case of acquired toxoplasmic retinochoroiditis, which can be easily diagnosed, and ELISA for toxoplasma helps in the diagnosis, and it responds to the treatment. Toxocariasis is called posterior pole granuloma, peripheral granuloma, chronic endophthalmitis like picture, And here is a case of posterior pole granuloma, and there is a peripheral granuloma of the fundus. And here is a case of TV granuloma in a 13-year-old boy before treatment and after treatment with ATT and steroids, complete resolution of inflammation. Rubella retinopathy, we can get salt and pepper fundus. Nothing much you can do about this treatment part of it as such. UVA specialists need to work with an infectious disease specialist in this condition. And this is a multimodal imaging in a case of bilateral frosted meningitis due to another virus, Epstein-Barr virus infection. This is a 5-year-old boy, sudden loss of vision in both eyes for 11 days, fever with maculopapular rash over thigh and abdomen. Vision is 3/60 in both eyes. And what the patient has got 1/60 vision in both eyes optos image revealed presence of characteristic perivascular sheathing of the vessels leading to the frosted meningitis. What we found in serology, anti-Epstein-Barr virus IgG was 420 international unit. Anti-rubella IgG was also elevated. You give an IVMP 250 milligram per day for 3 consecutive days, followed by the oral prednisolone with slow tapering and tablet valaciclovir. And the patient responded elegantly with the treatment, and there is a decline in the anti-IVB titer also. Last but not the least is the 8-year-old girl, no pain, redness, white hypopyon, not responding to topical steroid. At this stage, we did anterior chamber tap, which showed basophilic cohesive cells with hyperchromatic nuclei and scanty cytoplasm, suggestive of retinoblastoma. So you need to work with an oncologist for further treatment of this patient. So this is a case of 7-year-old girl. This is the last case. The child presented with a complaint of blurring of vision in the right eye. He was a known acute lymphoblastic leukemia and then was currently on treatment. And this patient had white convex hypopyon, eyes infiltrate, and there is a bumpy iris was seen over that one, and then the AC tap showed lymphoblast cells. And this patient was referred back to the oncologist, and chemotherapy was started, but the patient did not survive. Child expired. This is a kind of a hypopyon in a patient with leukemia is a ominous sign, and it indicates a recurrence of the lesion. So what we need in case of pediatric uveitis, many of the times we work with rheumatologists, infectious disease specialists, nephrologists, and dermatologists. But if we can work together, the results can be gratifying. And this is one of my patients with pediatric VKH who draw the photograph sketch of mine and presented to me. So all of you are to do work with the various specialists to treat pediatric uveitis, because it can be a vision-threatening disease, and it can be very gratifying if you can treat them well. Thank you very much. This presentation from Shankar Pala, our department on behalf of the colleagues. Thank you very much.
Thank you, sir, for such a wonderful and comprehensive talk. We truly learned so much from this talk. Before we move on to the next speaker, I would like to invite anyone, if anybody has any comments, especially the chair of our session, Professor Pradeep, Dr. Rohan.
Dr. Pradeep, sir. So, sir, in pediatric uveitis, you have covered a lot. So, all of us are now dabbling with these new anti-TNF alpha agents. So, one thing I just wanted to ask you, in your opinion, sir, after how many doses of adalimumab do you think it really comes and we are able to reduce the steroids?
Can you repeat it? The sound is very less.
Sir, can you hear me now?
Yeah, I can hear now.
Okay, sir, in your opinion, once we start these agents like adalimumab in pediatric uveitis, after how many doses do you think on an average that in most patients some results start coming and we are able to reduce the dose of topical steroids?
Yeah, so 3 months, 93 months injections, I told once they start. So you can start seeing the results after 3 months, like 6 doses of injection adalimumab. So when you start talking to them, we tell them that it will require 6 injections for so far as much as possible. After that, you can space out space out like once in 2 weeks to once in 3 weeks and once in 4 weeks, though it's debatable. But 6 months, 3 months, I give the treatment for the beginning itself, and then titrate the dosage of methotrexate and steroids win off the steroid. It's
Thank you,
really
sir.
changing that pediatric uveitis now non-infectious type is very well treated with biologic agents, anti-TNF alpha inhibitor, particularly injection adalimumab. We have published a series in IGAO recently, and all of us, I would encourage to try whenever possible to give in non-infectious pediatric anterior uveitis, GIS uveitis, to switch over to injection adalimumab is a very good drug, targeted therapy.
Thank you, sir. Ananya, we
Yeah,
can go
thank
with
you,
the next.
Rohan.
Yes, sir.
Yeah, no, I just wanted to thank Dr. Biswas sir for gracing the occasion and joining this virtual session. Thank you so much, sir.
Thank you, Pradeep.
Thank you, sir.
Thank you, sir. So our next speaker is Dr. Mudit Tyagi, and really very, very good clinician and an excellent vitreoretinal surgeon from LV Prasad, Hyderabad. Sir, we all know him for his extensive work in ocular syphilis. Today, he's going to be talking about identifying retinal infections, clinical cues, and patterns. Over to you, sir.
Yeah. All right. Thank you so much. Are my slides visible?
Yes,
Am
sir.
I-
They are. Yes,
Yeah.
sir. You are audible. You're
First
visible.
of all, let me thank the entire team from All India Institute of Medical Science and RP Center for having me here. It's indeed a privilege and honor to be speaking among such an august gathering. I apologize, I have kept my video off. I've got some network connectivity issues, so I just thought I'll keep the video off. So I'll be talking in the next few minutes about how we can identify a lot of these retinal infections just on the basis of the clinical appearance, and how just basic pattern recognition and looking carefully at clinical clues can help us in arriving at an etiological diagnosis, even in the absence of specific lab investigations. So that's the beauty of most of these retinal infections. The fact that in most cases, a good clinical evaluation can help you in arriving at what's the underlying diagnosis. Now, two of the most common presentations that you will come across and which may occasionally cause a bit of a dilemma are what's the level of involvement? Are you dealing with a retinitis or a choroiditis? And clinically in itself, you can, in most cases, appreciate and make a decision on that. So if you look at a retinitis lesion, these are usually superficial and they end up obscuring an underlying blood vessel. So if you see a superficial lesion and you do not see an underlying blood vessel, then it kind of makes your diagnosis clear that you are dealing with a retinitis lesion. Choroidal lesions, on the other hand, as the name suggests, are deeper. And because they are deeper, you will be able to appreciate the blood vessels coursing over the choroidal lesion. So that's how you clinically can. But so this is what I was talking. So if you look at this over here, you have a superficial lesion which obscures vessels. It's a retinitis lesion for you. But if you look at the right hand side, you see this other lesion over here, which is deeper, and you can see vessels coursing, and that helps us understanding the fact that you are dealing probably with a choroidal involvement. Now, if you just look at the fact that happens in terms of angiography, a dye-based angiography in OCD again can be very valuable clues in differentiating between them. So, what's the point to look at? Look at early hypo happens subsequently in the terms of the hyperfluorescence that happens in an FFA. So in a dye-based angiography, if you see an intense hyperfluorescence and then lesional hyperfluorescence, that is a clue to dealing with a retinitis lesion. Whereas if you see a hyper and becomes a diffuse hyper in the lesion, then that usually happens in choroidal lesion. So based on an FFA itself, if you see an intense hypo followed by a perilesional hyperfluorescence, think of retinitis. If you see a diffuse hyper, which in the and the third may occasionally be a scleritis and multiple point on a scan can help in differentiating. So let me show you a few clinical scenarios where clearance and patterns can help us in recognizing what you're talking about. So ocular TB in itself has got a few characteristics. Is the presence of subvascular where it is of vascular pigmentation is that is a very strong fact that we probably lead to glucosis. Simply a lesion which is a retinitis with blood. A careful examination might over a person in a clue to tubular retinitis. So these two clues, retinitis problematis, a subvascular yeah.
No.
Can you
Sir, your audio, sir.
yeah, can you hear me?
Yeah, you
Yes,
can hear.
sir. Now,
Again, a serpiginous like choroiditis again has got a very characteristic appearance where you can see these choroidal lesions sparing the peripapillary area, and that can help us in this. Moving on to some very common retinal infections, toxoplasmosis is one of the most common unifocal cause of retinitis that we encounter in a clinic. So if you see a patient with a single unifocal retinitis, think of toxoplasma as one of your most common differentials. Can happen in immunocompetent as well as compromised host, and there is no consistent direction of spread. Often it can be associated with an intense inflammatory response. So if you see a very thick, intense inflammatory response, then two of the most common differentials are either an acute retinal necrosis or a toxoplasma. But how do you differentiate them? Look at the area of involvement. Usually toxoplasma involves the macula in most cases and is a unifocal lesion. Acute retinal necrosis, on the other hand, is more common in the periphery with peripheral confluent lesions, and I'll just show an example of that in the subsequent slides. Another clinical clue is occasionally what we see is the fact that toxoplasma occurs at the edge of a scar. So if you see a scar and you see a retinitis adjacent to the healed scar, that again is a strong clue to the fact that you're dealing with toxoplasma retinitis. So this is like what I was saying. This is a patient who's got these multiple scarred lesions, and then you see a reactivation of a retinitis lesion at the edge of the scar, a clue to ocular toxoplasma. Now, how does reactivation help us in differentiating? Remember, toxoplasma retinochoroiditis occurs at the edge of a scar, whereas in cases of TB, you will see a reactivation within the scar. So reactivation from the center of scar, think TB. Reactivation from edge of the scar, think of ocular toxoplasma. If you see a patient with multiple retinitis lesions, areas of hemorrhages, some central clearing, but surprisingly, you do not see intense vitritis or AC or vitreous reaction, which is commensurate with the retinal involvement, then that's a clue to the fact that you are dealing with a patient who is immunosuppressed, and therefore the patient does not probably have the capacity to launch an immune response, and that's the reason for the paucity of vitritis. So you see these multiple retinitis lesions can be a clue to underlying cytomegalovirus retinitis. Usually, like I said, maybe wedge-shaped lesions with associated hemorrhages. The characteristic pattern that you may find are the one which we call like this tomato ketchup sort of an appearance, but more commonly you may occasionally also see a frosted branch meningitis. Like I said, you will see a minimal or absent vitritis in these cases. You can also see a fulminant form of CMV retinitis, where the most common cause of vision loss is a macular involvement or a granular form, which may subsequently lead to detachment because of the granular areas undergoing necrosis and creating multiple periphery. So like I said, a perivascular form or a frosted meningitis can all be seen, and you need to remember that the common causes of frosted meningitis are also, apart from that, idiopathic, can occur in Behçet, sarcoidosis. So you need to rule out these differentials, including lymphoma, leukemias, and SLE. I don't talk on discussing syphilis. It's a disease which is most often identified on the basis of its clinical appearance. So if you see a ground glass retinitis with the cell clearing, or you see these multiple small lesions, think of syphilis as one of it. Apart from that, the most commonly choroiditis, placoid or chorioretinitis, intense infiltration at the margins. That again is a very strong clue to the fact that you are dealing with ocular syphilis. And if you do an OCT, you can see an RP nodularity. So RP nodularity in the placoid, if an OCT to the really full thickness, retinal involvement. So these are again strong clues to the fact that you are dealing with ocular syphilis. So this is what we are talking about, a full thick lesions. So these are the characteristic patterns where you see placoid chororetinitis with intense marginal infiltration, ground glass retinitis with central clearing, or miliary lesions. All of them are clues to the fact that you are dealing with ocular syphilis. So let me just show you one case which illustrates what I'm talking about. So this was a patient who was referred to us. This patient was initially thought of as having an intermediate uveitis, then was thought of as having a posterior uveitis, was treated with IV methylprednisolone. The patient did not improve, started on steroids, started on immunosuppression. When the patient did not improve, was finally given Ozurdex, and you can see these implants in both the eyes. But when the patient came to us with multiple small mirror lesions beside the bell ringing, we got the patient investigated. The patient positive for both HIV as syphilis. How strong a clinical clue can be these miliary lesions? So you see them syphilis. We already spoke of necrosis can have a dense vitritis, but this is how it is when you use peripheral multiple. Think of acute retinal necrosis as one of your differentials. Progressive outer retinal necrosis, severe very low counts, positive. You see this posterior and pole involvement and this mud crack sort of a retinal appearance with sparing of the perivascular areas. So that is a common pattern for PORN. I will quickly just go through fungal endogenous and slightly different patterns of involvement. Aspergillus is usually more fulminant and confined to the subretinal space. So yes, OCT itself, a lot of times you can make a differential. This was a very nice paper by Dr. Irvisi. The group where they had essentially shown how a rain cloud sort of an appearance can be there in what you see in OCTs. So this is what you see otherwise in an aspergillus, where you see this intense subretinal involvement. So let me just show you quickly one of our patients. So this was a patient who came to us with bilateral retinal lesions. And when we did an OCT, what we found that there was this subretinal lesion. And then subsequently, we found that it also had a small choroidal involvement. Now, if you do multiple scans through the other eye, you see this area where the lesion has broken through the retina and you can see this exudates encroaching to the vitreous cavity. So like what was described as a rain cloud sign. So this was a clue to the fact that you're dealing with probably a candida endophthalmitis. We did a vitrectomy and a biopsy, treated the patient with the intravitreal amphotericin B, and the patient responded to treatment. Nocardia and diseases, but just wanted to show you how pattern recognition is important. This is one of my last cases for this talk. So this was a patient who was initially treated as acute retinal necrosis, was given intravitreal ganciclovir as well as velacivir. But when we saw the patient for the first time, what we noticed was a scar adjacent to the lesion. So the scar with the retinitis, if you remember, I just told you, is a clue to ocular toxoplasma. So we stopped the antiviral, started this patient on Bactrim DS, and this is how the lesion started responding. And after 3 weeks of treatment, most of the lesion has regressed. So in a nutshell, clinical signs and clues can be a very important investigation and a very important clue and a pointer towards arriving at a clinical diagnosis. And it's important for us to be aware of these patterns, look for them, because clinical examination in itself can save us a multitude of lab investigations and help us in arriving at an early diagnosis. Thank you so much.
Thank you,
I'm
sir, for
sorry
the
if I
wonderful.
exceeded the time.
No, that's okay,
Yeah.
sir. Thank you, sir, for this wonderful talk. It was truly really good to know of all these various presentations that are there. I would like to invite any panelists, whether they have any comments, any questions for sir. All right, I think you've cleared confusions of everybody. So thank you. Moving on to our next speaker. Yes. Moving on to our next speaker. Our next speaker needs no introduction. Dr. Anirudh Agarwal. He is currently working at the Eye Institute of Cleveland Clinic, Abu Dhabi. And prior to this, he has trained and also worked as an assistant professor in PGI Chandigarh. We know him for his prolific research work in almost so many topics related to vitreoretina. Over to you, sir. He'll be presenting about paraneoplastic syndromes in uveitis.
Hello, good afternoon. Can you hear me?
Yes, sir, you're audible.
Great, thank you. It's a pleasure, honor to be here. Thank you to the entire team of RP Center. Many congratulations on the 50th day and Founders Day. And thank you to Dr. Shaurya as well for this kind of opportunity. Also, my regards to the panelists, Professor Pradeep Venkatesh as well. So my topic is slightly, the off from what Dr. Biswas and Dr. Mudit have spoken about. I'll be talking about some of the new entities that we are encountering in clinics these days, which include paraneoplastic syndromes. And primarily, I will focus in the next 10 minutes on something that we already have heard of before, which is cancer-associated retinopathy, melanoma-associated retinopathy, B-dump, and paraneoplastic optic neuropathy. So I'd just like to acknowledge Dr. Peter McCluskey from Australia for some of the cases shown here. So in general, paraneoplastic retinopathy is an umbrella term, and it includes several entities, all of them which present with retinochoroidal manifestations associated with malignancies, usually present at a distant remote site, not in the eye necessarily. And the common clinical features of this condition include presence of, often they come with progressive, often rapid onset visual loss, and they may have non-specific visual phenomena such as scotomas, photopsias, or patients may have vague complaints such as seeing sparks of light or seeing some vague kind of arcs of light or shiners in their field of vision. Clinically, they may present with optic disc edema or atrophy, and they often don't have obvious signs of inflammation like cells or KPs in the anterior or posterior segment. The spectrum is very big and it essentially includes cancer-associated retinopathy, melanoma-associated retinopathy. We also have the Lambert-Eaton syndrome, which is associated with myasthenia, bilateral diffuse uveal melanocytic proliferation, which is B-dump, but we also now are seeing a lot of unilateral cases. And we also have paraneoplastic optic neuropathy. They are associated mostly with common malignancies, including small cell lung cancer. We also have solid organ malignancies like breast, uterine, and thyroid cancers, renal cancers, pancreatic, and also blood tumors such as myeloma, lymphoma, and others such as colon and prostate. The pathogenesis is very difficult. Till date, even we don't have a very clear idea of how these uveitis are caused. They probably, it's a presumptive mechanism that is described, probably from the antibodies which are cross-reacting, such as the anti-retinal antibodies, commonly the anti-recoverin and anti-alpha enolase antibodies. These are the most common ones, but you have hundreds of other antibodies which could be present, and there could be a molecular mimicry that could be an inciting cause for paraneoplastic uveitis. And also, the confounding factor here is that if you test normal healthy individuals, almost 40% or more may have presence of these antibodies. So there are in fact papers which have patients of VKH, another disease, and if you test their antibodies, they may be positive. So this is a problem with the anti-retinal and other, the antibodies which are circulating in the blood. We don't know if there is a direct link. So a typical patient in your clinic will be the one who is elderly, either male or female, presenting usually before the malignancy in the body is detected, but it could be after. If it is after, it makes a life easier for the ophthalmologist to diagnose, and it can mimic retinitis pigmentosa. You may have 1/5 patients with a completely normal looking fundus examination. Paraneoplastic, we have a longest follow-up in literature of 32 years, before the description of the paraneoplastic retinopathy. So there could be several decades before the actual diagnosis of systemic malignancies. So in general, suspect when the patient is older age group, unexplained visual loss with visual phenomena, sometimes bony spicules, pigmentary changes may be there with normal examination, but there are symptoms, and these are signs of an occult malignancy. The key points here are that there is going to be a photoreceptor dysfunction with rod and cone dysfunction, visual field defects, optic disc pallor, color vision changes, photosensitivity, and changes on the ERG. And autofluorescence is very useful. You'll have this pattern of stippling, a mixed hyper and hypo. In the center, usually a diffuse hyper autofluorescence, and in the mid periphery, you will have these hyper diffuse spots, granular stippled hyperfluorescence, and hypo. So autofluorescence is a very important imaging tool, screening tool, which shows you changes in the posterior pole and mid periphery. And on the OCT, you will have a very distinct kind of a microcystic edema. And on the infrared, corresponding infrared and autofluorescence, you will see these parafoveal spots, which are very characteristic also. And on the OCT, you will have a loss of the ellipsoid zone, and there may be affection of the outer nuclear layer as well. CME can be present frequently. So these are the changes that you see on the OCT. Now, this is a patient of B-dump. This is a lady who presented with ovarian cancer. And if you look at the fundus examination, you may not see much on the clinical exam, but the autofluorescence is so typical. And you have diffuse round to oval hypoautofluorescent dots studied across the autofluorescence, and the OCT is also very typical. This is a case of B-dump. I haven't shown the other eye here. Apart from imaging, electrophysiology is very important in diagnosis of paraneoplastic. On the ERG, you will find reduced amplitudes of A and B waves, delayed waves. Electronegative ERG is characteristic of CAR. And of course, in general, as a patient walking into your clinic, what you could do is search for malignancy. But you may not be able to do autoretinal antibodies or anti-retinal antibodies, because they are not available in general world over, and very few select centers internationally have this available. One thing that you should rule out is azure, and that is done by imaging. So if you do good autofluorescence imaging, you may be able to rule out azure, because that is again a specific cause for the changes that you see in these patients. This is a patient who took me by surprise, a 76-year-old male. I did surgery for him for epiretinal membrane in 2022. He had a very much appealable membrane on OCT preoperative with visual acuity of 20/50, no systemic illness. Surgery was very uneventful. This is how the OCT looked like. And if you see the infrared, lots of striations there. So I peeled, I did a very uneventful surgery for him. This is post-op. He did improve to 20/30 in the post-operative period. And 1 year later, he presented to me with rapidly decreasing visual acuity in both eyes. So I was not able to understand why the visual acuity was 2100 in the right eye, 2150 in the left eye. And this is the OCT infrared, how it looked like. So there were no striations, nothing obvious. I did his visual fields and OCT nerve layer to look for any dissociated nerve fiber. Nothing, obvious on the OCT RNFL. Some central scotomas on visual field. The autofluorescence also does not show any significant changes here. It's quite okay looking, nothing much from the surgery, no iatrogenic injury in this eye. And so no RPE loss, no DONFL. He had some vague history of hemochromatosis, nothing significant. He underwent genetic testing, again, nothing significant for hemochromatosis. And look at the pattern ERG, and the multifocal ERG was completely flat, obliterated photoreceptor rod and cone function. The light adapted ERG was also very much suboptimal in both eyes. The other eye was also affected. So my presumptive diagnosis was paraneoplastic, and sure enough, 6 months later, he was diagnosed with non-small cell lung malignancy, and he's currently on therapy for that. Now, the problem with antibody testing is we have the option of sending it to the US, Oregon, Portland from here in Abu Dhabi. But, the problem is that there is a lot of discordance. These tests are non-standardized, they're not validated, and antibodies can exist in normal individuals also. So possibly the antibody testing is of no value and diagnosis is of exclusion. So what can we do? We can treat, we can detect the systemic malignancy and look at the visual function, but there is no standardized protocol for systemic immunosuppression. People have tried local therapy or even IVIG. IVIG is something that has to be repeated. It's not a very easy therapy. And plasmapheresis or systemic immunosuppression with rituximab. Many centers are now doing rituximab. And something that is upcoming now is local therapy with Ozurdex. This is something that is really upcoming and can help also in cystoid macular edemas. So again, summary here, key points. challenging diagnosis, challenging lab interpretation. Often it's a diagnosis of exclusion, and we don't have really a pinpoint antibody that can diagnose the disease very clearly, and there is no consensus for the treatment. So with this, thank you very much once again to the team RP Center. Many congratulations, and thank you very much for inviting me. It's indeed a privilege and honor. Thank you.
Thank you so much, sir. Thank you for explaining such a unique topic so wonderfully.
Thank
I
you.
would like to ask if there are any other questions from any of our panelists or the chair.
Panruddha, how do you treat a car patient? You yourself, how do you treat? There is no consensus of opinion, and I have few patients, I don't know how to treat them. They don't respond to the
Yes.
treatment.
So in general, sorry, in general, the treatment would be a couple of things. One, if you have to work with the oncologist, and if the oncologist is okay giving systemic immunosuppression, usually they are fine with it. And then in those cases, we choose either rituximab or we go with a non-biologic therapy like CellCept, mycophenolate, something which is easily tolerable. So CellCept is something that can be tolerated by most patients. If not, then rituximab is the option. In cases where systemic immunotherapy or chemotherapy is interfering with rituximab or CellCept, then I usually do Ozurdex, an implant. So Ozurdex or Iluvien implant. Iluvien, in my mind, doesn't work very well for other uveitis, but in this kind of CAR or MAR, Iluvien is an option, a long-term option. And then usually I follow up with visual field and ERG. Periodic ERG should be done.
Yeah. I have treated microfibrillary mofeted patients. I've given Ozurdex also, but their visual field goes on deteriorating.
They will
So,
have, unfortunately, a downhill course. Unfortunately, it is a disease which will progress. Only thing you can do is decrease the or delay the progression of the disease. That's all.
agree.
I think the other importance is of diagnosing before the patient has developed a malignancy. I think in
Yes,
those cases, if one suspects it with the high index of suspicion and can detect the systemic malignancy early, that would benefit the patient a lot.
absolutely.
Sir, I have a question. I mean, with the newer chemotherapeutic agents and all that, is it really necessary for us to treat the CAR or the MAR? I mean, because patient is anyway on a very systemic, and very
Yes.
newer therapeutic agents have a very good efficacy. So what if we leave alone and just wait for the whatever
Yes.
healing may just occur with the systemic?
That's a great question, ma'am. And so there is a big topic here, but in brief, for example, if you have a non-solid tumor, like if you have myeloma or lymphoma, in general, you don't require any systemic immunosuppression to go with the CAR or MAR. But if it is an unrelated tumor like prostate, where the patient is treated with, let's say, bladder BCG, or is a very local therapy, or a very specific immunotherapy, in those cases, it will not cover the eye. And so you will have to treat with systemic immunosuppression or at least a local therapy. Some patients I have seen of multiple sclerosis and they're on ocrelizumab and they show very good response to uveitis also. So I think you have to study the agent which is being used for chemotherapy, and maybe it has a very good effect in the eye as well. But if it is a very local therapy, like it's a prostate or something, let's say estrogen therapy for ovarian cancer, then in those cases you will have to supplement.
Yeah, Anirudh, two questions.
Yes, sir.
Pradeep here, Anirudh. Thank you for joining in. Yeah,
Thank you, sir.
one is, do you have any kind of result from histopathology, either from literature, any cell-specific molecules that have been targeted or with immunohistocytology or something, IHC staining or something? That is the first thing. The second thing is there any neurological features also ongoing in the brain, any CNS correlations?
Both great questions, sir. I think for B dump, there are cases of unilateral dump which have published cases. I have my knowledge from those cases. I don't have personal experience of histopathology, but in those described reports, the histology shows only melanocytic proliferation only. There are no cancer cells which have been detected on histopathology. No direct infiltration has been detected. And on immunofluorescence staining, again, they are able to detect only stains which are specific to melanocytes. So this is a very primitive area of research. They haven't found much really. I did not find anything exciting in terms of proteomics or any other markers. I haven't come across that. Maybe I should go back and read. As far as CAR and neurological symptoms, again, I'm not particularly aware if there are neurological features, but probably these patients are predisposed to getting these neurological conditions as well.
May
Thanks.
I add a one point? I have got a one patient who has subretinal fluid. A B-dump patient was given as well as a vitreous fluid. Vitreous fluid doesn't contain any cells, but that subretinal fluid showed benign melanocytes. So
Yes.
melanin-bearing cells, benign melanin-bearing cells, there is no malignant cells, no inflammation was there.
Yes.
This said by Dr. Shahana of a BDAM case, proven BDAM case with OCT findings.
Great, sir.
Thank you, sir. Thank you.
Thank you. Thank you.
Thank you, sir. So moving on to our next speaker. For our next speaker, we have Dr. Reema Bansal. She is a professor at PGI Chandigarh. We all know her for her extensive research, especially in tubercular uveitis. Ma'am will be talking about proteomics and uveitis related to tubercular uveitis. Over to you, ma'am.
Thank you. My slides are visible.
Yes, ma'am, they are.
So thank you very much. Congratulations RPC for the 58th annual Foundation Day, and thank you, Shaurya, for inviting me. Proteomics in uveitis, and with a new frontier in tubercular uveitis. So the word proteomics comes from the proteome, which is protein complement expressed by a genome. So this is how the proteome word comes from, and it involves the large-scale analysis of proteins, whether it's in a cell or a tissue or the whole organism. The proteins determine the biological state of a cell, and when it comes to human vitreous humor, there is a huge catalog of proteins published in the human vitreous. Coming to the proteomics in uveitis, when there is any disease of the retina or uvea, there is disruption of the blood-retinal barrier, which generates changes in the biochemical or protein composition of the ocular fluids and tissues. And this provides the basis for identification of biomarkers in these diseases. So most of the parts of the human eye have been used for proteomics in research, including the intraocular fluids like the vitreous, aqueous, tears, cornea, lens, ciliary body, retina, choroid, and the RPE. A number of animal models have been studied for proteomics in uveitis, and coming to the human studies in proteomics in uveitis, by and large, they are limited to autoimmune uveitis. So coming to the already published reports in autoimmune uveitis for proteomics in Behçet's disease, where the authors studied serum samples from patients of Behçet's disease and compared them with PKH in healthy controls. So they identified a proteomic expression which was different in the Behçet's disease patients as compared to the others. And another study in the CTDP1 was validated as a novel Behçet's disease marker, which was different from the other patients. Even the tears have been explored in patients of Behçet's disease, and it was found that the proteins were differentially expressed between the tears of the active eye versus the tear of the fellow eye, which was quiet. In GIA-associated uveitis, transthyretin or the TTR has been reported as a potential intraocular biomarker coming from the aqueous fluid, and tears have been explored for proteomic studies as well in GIA and have been reported to have similar cytokine profile to the aqueous humor in childhood uveitis, chronic uveitis associated with arthritis. In ankylosing spondylitis, patients have had increased levels of anti-PFD-N5 antibodies, and this has been found to have a protective role against cell death in uveitis. In unilateral acute anterior uveitis, ApoBic3A has been found to be significantly increased and TGM2 significantly decreased in tiers of diseased eye compared to the other fellow eye, which is healthy. So this suggests involvement of the inflammation-associated LXR and RXR pathways. Coming to VKH disease, decreased expression of CD18 and AKNA in peripheral CD4 T cells of VKH patients have been reported. So now, infectious uveitis, it's a different ballgame altogether. So we studied the proteomics in TB uveitis with a little bit of background as have MTB proteins being reported in the CSF samples of TB meningitis patients and also in the brain tissue of confirmed cases of TB meningitis. So the hypotheses were that the proteins could be expressed in intraocular fluid also of ocular TB patients. So we conducted this study to identify biomarkers for intraocular tuberculosis in the vitreous fluid by proteomics. So we had 3 groups. Group A had 13 patients of intraocular TB. Group B had 7 patients of non-TB uveitis, and Group C had healthy controls who did not have any uveitis, and the vitreous fluid was collected from these eyes which underwent surgery for epiretinal membrane or macular hole and so on. The proteomics, these are the main steps. The protein estimation was done from the vitreous fluid, and then the shotgun proteomics was done, followed by LCMS mass spectrometry, where the samples were run in duplicates. So this is a very crazy raw data of all the samples. Just to highlight the yellow column, which shows the log2 fold values on the basis to be overexpressed or underexpressed. So we found that when we compared group A with group B and C together, that is TB versus non-TB uveitis, group A versus B, we excluded the healthy controls. We found that there were 58 proteins which were differentially expressed, out of which 21 were upregulated, and these are the top 5 of the 21 upregulated, and these are the top 5 of the 37 downregulated proteins. So when we searched these proteins using all the possible permutations and combinations, we found that these proteins were associated with apoptosis and classic pathways among the list of the upregulated proteins. And among the list of the downregulated proteins, they were mainly associated with mTORC1 signaling and glucose metabolism pathways. So this study provides a baseline to explore vitreous biomarkers for ocular TB, hence opening a new frontier in TB uveitis. So this was our publication in the journal Tuberculosis with the entire team which worked on this research work. This is just a review on various protein biomarkers in all types.
Recording in progress.
Thank you, Dr. Rima. This is a new area of work and you're pioneering in this. That is great. Thank you so much.
Thank you.
We can move to the next speaker, I think.
So our next speaker is Dr. Vijay Tomar. He is currently a senior consultant at the Regional Institute of Ophthalmology in Sitapur. Sir is trained in UV and medical retina from Shankar Nethralaya, Chennai. And today he's going to be talking about managing uveitis, something much more than steroids. Over to you, sir.
Thank you so much. Good afternoon, everybody. Thank you so much for inviting me in this wonderful academic feast on the occasion of 58th Foundation Day of RP Center. So the ultimate aim in the management of the treatment of uveitis is to achieve the complete remission. And in majority of the cases, we achieve this either by the means of topical steroids or oral steroids or depot injections or by the means of IV administration of steroids. But steroids are found to be associated with the plethora of adverse effects ranging from dermatological manifestations to the neurological manifestations. And here, actually, we should have to think beyond steroids. And here comes the role of immunosuppressive agents first. But the major dilemma in the minds of general ophthalmologists is when to use, which one to use, and how to use. So the first question, when to use? They should be instituted when a patient is having severe sight-threatening uveitis despite the appropriate steroid treatment, or the patient is having recurrences as soon as you are reducing the dose of the steroids or stopping the steroids, or the patient is having steroid-induced adverse effect. But you will have to be doubly sure that it should be of non-infectious etiology and there shouldn't be any systemic contraindications to these drugs. Before starting these drugs, you will always have to rule out any hidden or latent infection apart from the well-being of the liver and kidney, as most of these drugs are metabolized in the liver and kidney. And we are having so many drugs in our armamentarium, ranging from antimetabolites to the biological response modifiers. The unique that unique the property of these drugs is they either inhibit the nucleic acid synthesis or protein or both. And now coming one by one, we all are very much familiar with methotrexate. It is a dihydrofolate reductase inhibitor, inhibiting the formation of single carbon unit required for the DNA synthesis and used very frequently in so many uveitis, which is recalcitrant to the steroids. It takes around 3 to 4 weeks to produce effects, and the major adverse effects are hepatotoxicity, pulmonary fibrosis, and myelosuppression. And in the cases of severe myelosuppression, leucovorin rescue is very, very important, and it should be started as early as possible, at least 6 to 8 hours after starting the methotrexate therapy. Methotrexate can be given maximum up to the 50 milligram, but its absorption is highly irregular after 20 milligram per week dose. So it is better to be given subcutaneously to have optimum effect. Always have a drug history, that whether your patient is on salicylate, sulfonamide, tetracyclines, or chloramphenicol, and if the answer is yes, always reduce the dose, because all these drugs increases the unbound fraction of methotrexate, leading to the methotrexate toxicity. Azathioprine is a 6-mercaptopurine, is indicated in so many uveitic entities, and it is very much effective in treating these entities. The onset of action, like methotrexate, is again, it takes 3 to 4 weeks, and this drug is hepatotoxic, so always have a liver function test at least at 1 month interval. If your patient is hypertensive and is on serum ACE inhibitors, always replace this serum ACE inhibitors from some other drug, because both these drugs can cause severe leukopenia if combined. And if your patient is on allopurinol, you will have to reduce the dose to prevent the adverse effect of azathioprine. Mycophenolate again is a very, very safe drug. It inhibits inosine monophosphate dehydrogenase and can be given in a maximum dose of 3 grams per day. The disease is very much well tolerated by children, like methotrexate, as this drug is having lesser side effect. The major adverse effects of mycophenolate is diarrhea and weight loss. Always give mycophenolate empty stomach, because it is absorbed very well in acidic medium. So if your patient is on antacids or PPAs because of oral steroids, always ask your patient to have this drug empty stomach in the morning for the better absorption. Cyclophosphamide is a alkylating agent, and this is the drug of choice in vaginous granulomatosis and polyarteritis nodosa associated scleritis or vasculitis. And this is the only immunosuppressive agent that induces immune tolerance to a particular antigen. So antigen priming should be done 24 hours before starting the cyclophosphamide. Cyclophosphamide causes myelosuppression, gonadal dysfunction, sterile hemorrhagic cystitis, and secondary malignancies. And hydration is very, very important when you are planning for cyclophosphamide therapy, because the metabolic product of cyclophosphamide, that is acrolein, irritates the bladder mucosa and causes sterile hemorrhagic cystitis. So always ask your patient to have at least 3 to 4 liters of water intake. The IV infusion offers rapid induction, transient neutropenia, and avoids prolonged bladder exposure to the acrolein. Cyclosporin is a T cell inhibitor and is very much effective, particularly in the pathologies where T cell is actually the culprit, like sympathetic ophthalmitis and VKH. And whenever you are planning for cyclosporin, remember that whether you are using a modified one or a non-modified one, if it is a modified one, the dose should be 20% reduced in comparison to the non-modified, that is the Sandy Immune. If you are using neo-oral, your initial dose should be 4 milligram per kilogram body weight per day. And the cyclosporin is nephrotoxic, hypertension, hepatotoxic, and shows gingival hyperplasia if it is used in the dose of more than 5 milligram per kilogram body weight per day. The major question is which drug has to be used? And the answer lies that what is the etiology behind this inflammation? What is the disease? What is the age and the gender of the patient? How this drug is acting and what is the adverse effect profile of this drug? Because you cannot institute methotrexate in a patient who is having deranged liver enzymes, or you cannot institute cyclosporin in a patient who is having nephrotoxicity or some nephrotic or nephritic syndrome. But what to do in recalcitrant cases, because sometimes even after switching one immunomodulatory drug to the other, we are not getting the appropriate results. And here comes the role of biological response modifiers, which are really the new game changers. Biological response modifiers are the therapeutic agents which are made through biological rather than the chemistry, and they are directed against a one particular cytokine or a one particular cell type or a cell surface receptors. And they are indicated in the patients who are not responding to the traditional immunomodulatory agents like Behçet's uveitis, GIA-associated uveitis, HLA-B27 associated uveitis, Blau syndrome, and recalcitrant non-infectious uveitis and scleritis. Adalimumab and infliximab are the two most common TNF-alpha inhibitors which we use nowadays. Adalimumab is a FDA-approved drug, and it is a fully humanized monoclonal antibody which is given subcutaneously, whereas infliximab is a chimeric monoclonal antibody. Hence, the chances of development of antibodies to infliximab are very high, but this can be reduced by the use of methotrexate while you are using infliximab. Sycamore study actually proves the efficacy of adalimumab in combination with methotrexate in the cases of GIA-associated uveitis, particularly in the adolescent and the pediatric subset. There are so many case reports and the clinical studies which shows the efficacies of this TNF-alpha inhibitors in the management of Behçet's uveitis. And apart from that, adalimumab and infliximab, golimumab is also very much effective in the management of Behçet's disease. The use of anti-tumor necrotic factor alpha agents has been shown by the various studies done at either Sankar Nethralaya and from the RP Center. And the other biological agent, which is really very interesting, is interferon, particularly their role in the Behçet's disease and in the patients of recalcitrant intermediate uveitis, which are found to be associated with multiple sclerosis. They are also very much useful in the management of sympathetic ophthalmitis and idiopathic posterior uveitis. There are many drugs which are directed particularly against certain interleukins like tocilizumab, which is effective against interleukin 6, then teclistamab, effective against CD25 receptors, and rituximab, which is effective against CD20 and is equally efficacious like cyclophosphamide. So the patients who are where we cannot institute cyclophosphamide because of its adverse effects or the disease is recalcitrant to the cyclophosphamide, rituximab is really a very great alternative to take care of these patients. Nowadays, we are having JAK inhibitors or jacatinibs, and these are not actually the biologicals because they are produced chemically, and these are small molecular drugs which are having targeted effect, and they are very much effective against recalcitrant scleritis. But we will have to remember that if we are planning to start biologicals, particularly the TNF-alpha inhibitors, our patients should be updated for pneumococcal influenza and hepatitis vaccines, and live virus vaccines are contraindicated in these patients. Children whose mother had been to TNF blockers should not be vaccinated with live attenuated vaccines until the 7 month of age. If a female who is pregnant and is on biologics, the only option is satolizumab, which is very much safe even up to the third trimester. Adalimumab is safe only up to the second trimester, and it is better to avoid pregnancy till 5 months after stopping the last dose of biologics. So the entire crux of this discussion is that immunomodulatory drugs and biologics are the new weapons to combat against non-infectious uveitis, and their judicious use is sight-saving. So thank you so much.
Thank you, sir, for your wonderful talk. Any questions?
Just want to make a comment. Earlier days, we used to use the methotrexate in low dosage, 10, 15. Nowadays, the term is to use the methotrexate in higher doses, 20, even 25. But still it is a slowly acting drug. I prefer mycophenolate mofetil in many of the cases than methotrexate.
Thank you, sir. Thank you. I think in the interest of time, let us move to the next talk. Dr. Ananya.
Yes. The next talk is by Dr. Sagnik Sen. Dr. Sagnik is currently a senior clinical fellow at St. Thomas Hospital, London. He's completed his MD from RP Center, and then he went on to do a postdoctoral fellowship and surgical fellowship in retina in Arvindai, Madurai. Unfortunately, sir is not able to be with us in person, but
I'm here.
you're
Sorry.
here. Okay, yeah, that's
Yeah,
great.
yeah,
That's
yeah.
great.
Yeah, I
All right.
managed to. I'm in the middle of theater. Actually, I couldn't manage time to keep this session free. So, yeah,
Yeah,
thank
great.
you.
All right. Over to you.
Can I share my screen?
Yeah, your screen. Okay. AV team.
So this is a case of a 62-year-old female patient who
AV team, please stop this recorded presentation. Dr. Sagnik will present directly from his device.
also had rheumatoid arthritis and alpha trait thalassemia. She was on some medications, cetirizine, statins, and metformin, nil allergies, and no history. Visual acuity in the right eye was fixed. She had grade 2 to 3 cataract in the right and pseudophakic in the left eye, with more or less within normal limits fundal examination in both eyes. So the patient undergoes. Can we stop this video, please? With lens implant.
Yeah, just a moment. We're just coordinating with the AV team. Just one moment.
Thank you.
Yeah, I think you should be able to share your screen now.
Is my slide visible now?
Yes, it's visible.
Okay, so good morning, everyone. It's my great honor and privilege to be here today. Thank you to all the faculties for inviting me on RPC Foundation Day for this talk. Okay, so I'm going to present a case of cefuroxime toxicity. This is a case of 63-year-old female patient who was referred to us for right eye cataract surgery. Systemically, she had a history of hypertension and type 2 diabetes, and she was on doxazosin, cetirizine, and statins, metformin for her systemic illnesses. Now, her vision in the right eye was 6/12 with a grade 2 to 3 cataract. The retinal findings were more or less within normal limits with no diabetic retinopathy changes. She underwent right eye phaco with IOL implant surgery. During the surgery, intraoperative PCR happened. So anterior vitrectomy was done. We could remove all of the pieces of the nucleus. There was a bit of complication while placing the sulcus IOL with AC bleed. And it was decided that the sulcus lens was not stable. So we explanted the lens, but there was a big corneal wound. Wound was sutured and the patient was left aphakic. And we routinely give all our patients intracameral cefuroxime, and this patient also got a subconjunctival cefuroxime as well. 5 days later, the patient had hazy cornea with a bit of soft lens matter retained. Vision was hand movements, pressures were normal. 10th day after postoperative, patient's cornea cleared with a better view of the anterior chamber. However, there was no clear view of the fundus. OCT was not done at this point. Vision was counting fingers and pressures were 11. She underwent a secondary sulcus lens implantation, and post-procedure, her vision improved to 6/18. Now, on the fundus examination, we found that she had a lot of yellowish, whitish subretinal deposits in the posterior pole, extending up to mid-peripheries. And on autofluorescence, you can see that she had these kind of hyper autofluorescent dots all over the macula and mid-peripheries. OCT changes showed subretinal deposits, extensive loss of outer retina, In the mid peripheries, you can see there was inner retinal layer schisis. However, the left eye was normal. Fluorescein angiogram showed that there was non-specific leakage throughout posterior pole and mid peripheries, and there was a bit of disc leak, but no signs of any vasculitis, retinitis. ICGA did not show any hypodots suggestive of any choroiditis, any vasculitis, no leakage. So we did a bit of uveitis workup for her. ACE, syphilis, TB, etc. were normal. Chest X-ray was normal. Vision at this point was 3/60. This was almost 2 to 3 weeks after post-op. And vision in the left eye was still quite good. Right eye showed clear cornea, pigments in the AC, signs of iris trauma. Sulcus lens was stable. There's no signs of vitritis. However, she persisted to have outer retinal hyperreflective dots. The plan at this point was to give local treatment with the right eye Ozurdex injection, and she was also on topical steroids. Now, on follow-up, 2 to 3 months later, Ozurdex had not shown any change in the outer retinal degeneration, and there was also overall retinal thinning with inner retinal skytic changes persistently seen, hyper autofluorescent dots all over the posterior pole. Left eye was still normal. Vision was 360 at this point. And 7 months after surgery, similar changes with extensive thinning of the retina, loss of outer retina, subretinal deposits. And at this point, we had stopped all treatment and prognosticated the patient that possibly nothing is going to improve. And visual acuity was stable at counting fingers 1/60. 8 months later, similar findings. And 1 year postoperative review, the visual acuity was stable at hand movements with similar findings. So we made a final diagnosis of cefuroxime toxicity of the right eye after complicated cataract surgery. Retinal features which have been described for cefuroxime toxicity are transient serous macular detachment with schisis-like appearance, which happens quite early on after the surgery, hemorrhage and mild tortuosity of vessels. They can also have widespread hemorrhages and optic atrophy, ellipsoid layer disruption, which was seen in our case, and pigmentary changes in the retina. Angiogram shows diffuse leakage. They can have normal retinal perfusion with no macular ischemia, and they can also have ischemic retinal changes with dye leakage. So this is a case of post-vitrectomy cefuroxime toxicity in which the patient presented within 2 weeks after surgery with widespread deep retinal hemorrhages and cotton wool spots, and FFA showed widespread diffuse leakage and ischemia. This is a case of post-trabeculectomy cefuroxime toxicity. Within day 5, the schisis-like changes resolved, and by day 9, it had improved further, and the outer retina had stabilized by 7 months with complete resolution of the toxicity, and visual acuity was quite good. Anterior segment toxicity features can show mild central corneal edema with anterior chamber flare and cells, cloudy edematous cornea with transient rise in IOP, loss of corneal endothelial cells as well, somewhat like toxic anterior segment syndrome. There is obviously a dose effect with cefuroxime toxicity with standard dose of 1 milligram or 2 milligram per 0.1 ml, ranging up to 100 milligram, which has been inadvertently administered in case reports published. And retinal toxicity appears rapidly with the effect peaking at 3 hours. And administration of higher volume but correct concentration can have toxicity. Eyes which have posterior capsular rupture can have toxicity because of the standard dose being absorbed more rapidly. And higher the dose, obviously, worse is the retinal toxicity. Now, in our case, patient had subconjunctival cefuroxime as well. So it has been hypothesized that subconjunctival cefuroxime can be absorbed through enlarged corneal wounds or even scleral wounds like in trabeculectomy or vitrectomy and cause inadvertently high concentrations in the retina. And specifically in case of post-vitrectomy eyes, there is no vitreous, so there's no buffer. So the toxicity happens directly at the posterior pole. Now, interesting features in our case is we did not have a proper examination done in the beginning because of corneal edema, and we did not have immediate postoperative OCT. So we don't know if the patient went through the cycles of cystoid macular edema and schisis in the macula. And long-term, so we saw the long-term consequences in which we had retinal deposits in the patient, and probably this was because of RPE toxicity. And we also noted peripheral retinal inner layer schisis, which has not been reported in literature that much. So this might be one of the atypical features of cefuroxime toxicity. Now, mechanisms of toxicity in our patient, possibly because of destruction of blood-retinal barrier and extensive leakage. Affection of the function of sodium-potassium pump of RPE has been described. And also immunohistochemistry studies of human retinal vascular endothelial cells have shown significant inflammatory effect on endothelial cells with extensive cell damage to inner nuclear layer cells. Management mostly is quite varied with different authors who have tried different management strategies. If the dilution error is detected early on, immediately after the wrong administration of wrong dosage, or if it was detected immediately, then you can do an immediate AC washout. Otherwise, observation is the first step. And topical oral NSAIDs have been described, topical steroids, local steroids like Ozurdex, and pressure control with acetazolamide. Prognosis-wise, it's also quite varied, with some cases reported with good visual acuity and some cases which had disastrous consequences with light perception vision or hand movements and even counting fingers vision. And mostly the visual prognosis depends on the extent of the initial insult. So with this, I come to the end of the talk, and I would like to extend my thank you to everybody again, to AIIMS, for inviting me for this lecture today. Thank you so much.
Thank you so much, sir. So we could take any questions before we close the session. So Dr. Rohan, Dr.
Thank
Pradeep.
you, Dr. Sagnik. These cases can be a nightmare, obviously, for the patient and definitely for the surgeon also. But I think, thank God, we are not using any of these prophylactic agents. I just wanted to ask you, are you using the prophylactic cefuroxime also for vitrectomies, vitreoretinal
Yes.
surgeries?
Yeah, so we are using, so there are a bit of differences in different centers, protocol-wise. So some centers are using intracameral, and some centers are using subconjunctival. So like in my center in St. Thomas's, we use intracameral cefuroxime. Basically they've done some scientific modeling, and as I said, like subconjunctival cefuroxime may get absorbed through the scleral wounds, whereas it's intracameral, probably there's still some compartmentalization happening. So yeah, but there are surgeons who are injecting subconjunctival as well.
I think
And
you can go ahead and tell them from your India experience that despite being India, we are not using any prophylactic antibiotics, and fortunately, our end-offs are
rates are
the
quite good.
percentage is
Yeah.
quite within international standards. Sir, Dr. Biswas, Dr. Rima, Dr. Mudit, any comments?
We
Dr.
are not
Preeti?
using.
They're not easy.
Nothing. Thank you so much.
One case
Well,
of toxicity and then you stop everything.
Yeah.
Yeah.
What is your experience with intracameral moxifloxacin though? Because I know that it is being used in Arvind when I was there.
No.
Some of the cataract surgeons at our center are using, but as a policy, we are not using.
Mm.
Sir, Dr. Pradeep, sir, would you like to say something?
Yeah, thanks, Sagnik. It's nice listening to you after so many years. And yeah, nice of you to join the session, Sagnik. Thank you so much.
Thank you.
Like, thank you so much, everyone, for this wonderful session. I think it was truly enriching to know about so many different topics, to hear all the stalwarts and uveitis talk about literally a myriad of presentations. So thank you. And yeah, I think after this, we'll close the session.
Thank you very much. It's an honor.
Thank you, everyone.
Thank you
Thank
so
you.
much.
Thank you, sir.
It was really an honor to be here.
Thank you.
Thank you. See you in AIIMS. How do you go out? Thank you very much. You have given me the thumb drive, no?
Yes, sir. I have given, sir.
Recording stopped.